When I began in paediatric occupational therapy, research into DCD was woefully inadequate. But by the mid-1990s, the McMaster University in Canada had pioneered the current system of evidence-based medicine with protocols for levels of evidence. Since then, multiple international conferences have produced a high degree of international consensus about DCD, well, between most countries. In 2011, the European Academy of Childhood Disability, EACD, published a guidelines paper called The Definition, Diagnosis, Assessment and Intervention of Developmental Coordination Disorder. The paper on this slide by Blank et al. Is a thorough revision of those 2011 EACD paper. It's heavy-duty, 43 pages of detailed discussion with references, plus 7 appendices and 19 tables, summarising the reviewed research. It's all quite a mouthful, but is interesting and full of research facts, and presented in a way that you can understand the basis of their recommendations. However, it is dense and very detailed. Fortunately, one of their appendices is a pocket version, presumably in recognition that we clinicians do not have the odd week spare needed to absorb the full version. It is a summary of their 35 recommendations. They label each recommendation with how it is derived, either from good clinical practice, as agreed by 90% of the international experts and in their literature search, or through levels of evidence, if it is from research. 27 of the 35 recommendations have to rely on good clinical practice, which speaks volumes about how little vigorous research has been done into the assessment and intervention of DCD. Of the 8 recommendations based on the levels of evidence of research, only 2 are the level of evidence grade 1, that is, this should happen. The rest are on grade 2. It is suggested that this may happen. DCD is still the Cinderella of neurodiverse conditions, with only a small percentage of research that's gone into speech and language problems and into ADHD. However, largely as a result of the international agreement, good research is being done. Recommendation 10 is that children with a diagnosis of DCD should receive intervention. Recommendation 22 is about the approach that should be used, activity-orientated and participation-orientated. On a personal note, I'm not entirely sure what these mean, but see the next slide. Also, over the decades I've noticed that general clinical practice can change in response to research, but also it can change as a fashion, a response to charismatic trendsetters. I personally apply the "does this make common sense" principle. If yes, then it's okay for me to use. If not, I ask why not. I would recommend caution about accepting this activity-orientated and participation-orientated approach as the only approach to be used. More about that later. Blank et al. Do include a list of things that they could be part of their recommended approach. Recommendations 18 and 26 are less controversial, I think. We'd all agree that individualised goal setting is essential and that physical fitness should be part of the programme if needed. Again, I think these 2 recommendations are common sense and should be applied. Blank et al. Actually don't point to specific games. Research is certainly promising in this area, but it's only been done on small niche groups, so be careful. This is another thick and authoritative paper, which is also in your handout folder. You et al. Only included random controlled trials. Teachers I have spoken to have found this a very useful addition to the framework of their handwriting policy, it gave them permission to address the underlying skills. Yu et al. Largely agree with Blank et al. About frequency and dose. Practice times need to be 4 or 5 times a week, not less. Training needs to last at least 9 weeks, and the total training time over those 9 weeks needs to be at least 10 hours. Where Yu et al. Disagree with Blank et al. Is about the effective approach. Yu et al. Found that a wider ranging approach to be most effective, a task process combined with process-orientated approach. They write, "This finding supports the use of a multi-level approach for children with DCD because of the multifaceted nature of the impairments of DCD. Applying my common sense principle, this does sound like common sense, since now we do know that DCD is multifaceted." Blank et al. Noticed several areas that need more research. Intervention, frequency and dose, more on that. Whether group therapy is better than individual therapy or vice versa. And does therapy work at school as well as at home? And lastly, we need to research more about outcome measures. At this point, I will add a note from my own research experience. In 2006, I ran a research study into the effectiveness of occupational therapy we were using in our paediatric occupational therapy department, using a quality of life questionnaire. Because it was the good old days, we had a 12-month waiting list, so the waiting list became the control group. We got 3 highly significant results. Firstly, the group who received OT, their quality of life significantly improved. This boosted our professional confidence. Secondly, the quality of life of the control group, matched for age and condition, slightly deteriorated. This helped prove to our managers that our funding should not be cut. Thirdly, one intervention subgroup, the group that only received advice sheets, actually deteriorated, the same drop as in the control group. So advice sheets are not the answer to active intervention. Unfortunately, advice sheets are becoming more and more common as the choice of intervention. It is very easy for management to say, "This is intervention," and tick the box that a client has received OT. This is woeful. It is just like the situation about children 30 years ago. Hardly any research. Now I am going to talk about some approaches to intervention that I've found to be extraordinarily helpful. The first is to find out what the client's strengths are and help them develop those. This list is from another research paper, and I apologise I've lost the reference. The important thing, though, is that motor skills are not listed as a predictor for success in life. A lot of encouragement there for kids with DCD. Reflection and thinking outside the box are frequent characteristics of people with DCD. Motivation and compliance, both are essential for success. So, the second approach is to pay lots of attention to whatever motivates your client, and hence gain their compliance. We all know that therapy is an art form, not a prescription, which is why advice sheets don't work. Excellent programs to develop physical skills have been around for at least 2,500 years. After this video, look at your handouts where there are details of lots of excellent packaged programs. The third approach is to be clear about why you are doing a particular form of intervention. This slide has the names of models, and the next slide has the names of some programs that fit into the models. And the next slide probably oversimplifies the approach, but here we go. The choices are: teach your client how to cope with DCD, or help them change their environment, or fix their problems by changing brain processing efficiency, or all three. This is the same way of looking at it, but with added information about ages. You're going to want to aim at different things at different ages. If your client is young, try to fix it. Teach them new skills. If they're older, 8 years old or older, with non-motor skills within the average range, then major on the goal plan do check technique. At any age, see if modifying the environment would help. One middle-aged client I saw lived almost underneath a busy flyover. The noise drove him to distraction. Really, moving house was his best option. It is a rare resource that puts these three areas together, but it is rare for people we see not to have some sort of problem in all of them. The star centre cards are A4 cards for sensory modulation problems, one each for under-responsive, over-responsive and sensory seeking, and a fourth card about positive behavioural strategies. They are truly amazing, a gold mine of information and strategies. When I got them, I put the information into a less crowded form and used them all the time. The rest of the session on intervention is presented in a PDF file. This is because there are so many details that you will have lost the will to live if I present them in a movie with hardly any video clips. The important thing is for you to know what approach to use. Please do ask any questions you have in a Zoom session. The PDF has a large section on handwriting. It is such a universal problem to those with DCD, young and old alike, and we have not covered it elsewhere. If you want to know more, and in more depth, the National Handwriting Association does an excellent 3-day course. The next slide contains my 3 top tips if you are really stumped. Thank you. For kids, I often have a joke book handy. Thank you.